Hi, everybody. It's Professor Miller. This lecture is going to focus on genes, the environment, lifestyle, and common diseases. It does coordinate with Chapter 5 in your textbook. I want to cover this in a little bit of detail. However, I want you to think about this from a broad perspective. It's really, really important as we move into advanced practice that you have a good understanding of risk factors and some of these genetic factors that contribute to disease development and some of those risk factors. And I'm sure you already have a fairly well understanding of risk, but a lot of this will feed into your ability to essentially come up with differential diagnoses. And I can't stress this enough. And you won't get into this until you start getting into like a health assessment course, but taking a complete health history or a health history that's focused on a patient's complaint, really having a good foundation of understanding risk factors and that genetic component that contributes to disease development or risk is critical, truly, to you having that ability to essentially diagnose patients as well. And preventative care is a huge, huge, huge thing in primary care. Once again, like I mentioned at the very beginning about shifting your thought process to acute care to more of that primary care mode, where we start thinking about prevention. And that's one of our biggest components of our position as a nurse practitioner, is focusing on preventative health maintenance. So preventing a lot of these diseases, if we can. Obviously not all of them you can, but we'll talk about that as we move through. These are just some general concepts, and I'm sure you've already been exposed to this at some point. But once again, it's important too, when you're looking at a disease state, like understanding what the incidence rate is and the prevalence rate, because once again, this will help you understand risk in patients or populations essentially. And usually, like when you look up any type of disease state, it'll typically give you like, it's more prevalent in this population, or the incidence has increased with this population. So understanding these general terms will definitely help you too, as we move further down the course too as well. So when you look at incident rate, that's obviously related to new cases. So these are cases that are reported during a specific period of time. It's typically over a year, divided by the number of patients in that population. So incidence is new cases, just remember that. And I have an image on the next slide that I'll show you that I added. Whereas prevalence is, number one, it's affected by incidence rate, and it's affected by other things like survival or death, unfortunately. So prevalence is actually the proportion of the population that's affected by a disease at a specific point in time. It varies from population to population, meaning that prevalence may be higher in one certain population, and it may be according to age, young versus old. Or, when you look at, a disease state, like you can think that, coronary artery disease is more prevalent in the older population versus younger. So you can look at it in terms of like a population of age brackets. Geographic locations is another one, underdeveloped countries versus developed countries. You're going to have more prevalence, or the rate might be higher in certain areas essentially. And things like culture can do that, or socioeconomic factors can change prevalence rates, descent, ethnicity, etc. Like a good example is sickle cell anemia. It's more prevalent essentially in African Americans versus Caucasian. That's just one example essentially. Another factor too, like even in your textbook, it brings it up about colorectal cancer. Rates of colorectal cancer are a lot higher in the US versus Japan. And a lot of this is related to our dietary factors, like a high-fat diet. And that's basically why we have a higher rate, or a portion of it essentially. So prevalence basically is looking at the proportion of the population, where incidence is new cases. I just added this in there because I feel like it's a good way to kind of look at it. They show, a bathtub. That's basically for incidence and prevalence. Incidence would be like flowing into the bathtub. That would be the new cases essentially that are contributing to that population, or the whole population that has the disease state. And prevalence, once again, is that rate is kind of determined upon the incidence, because obviously if you have higher incidence, it's going to increase that prevalence. If you have deaths, then you're going to decrease that population size. If you prevent deaths, so treatments, like a good example would be HIV. Like nowadays we have a lot of great HIV treatments. So the prevalence might be a little bit higher basically because we're preventing deaths and increasing survival rates. So you have a higher prevalence because of that. Or your prevalence can kind of go down because they may have passed away essentially, depending on the disease state that we're talking about. I just added the image at the bottom too about HIV, looking at prevalence essentially within that population range, that age bracket of 15 to 49. They might have a higher prevalence in that younger age bracket versus somebody that's 85, or 75 to 85. 7,000 new HIV infections in that year would be your incidence rate. So those are just examples essentially of incidence versus prevalence. And like I said, it's really important to understand this because when you if you look up any disease state, it's going to give you those, statistics or rates essentially. And when you're caring for your patients, it kind of gives you an idea of like, hey, what is my patient at risk for? I have a 55-year-old male, they have this background. It kind of helps you formulate things that you're looking for in that patient that you want to prevent, or if you're suspicious of a disease, essentially. Analysis of risk factors. So once again, I'm sure you're all aware of risk factors, and risk factors are huge contributors to disease. And relative risk is a term that's often used. And we look at like relative risk in terms of looking at a risk factor if they're exposed to a risk factor. And it's really, I don't expect you to memorize these formulas or anything like that. I just want you to understand the concept here of relative risk. So basically, those individuals that are exposed to a risk factor divided by the incident rate of disease among individuals that are not exposed to it. So a good example would be comparing non-smokers to smokers and the outcome of lung cancer. Obviously, the risk is going to be much higher in those patients that smoke and, outcomes of lung cancer. So you're giving a relative risk number, and it's usually given in a percentage, saying, out of this population, that relative risk of smokers with the outcome of lung cancer would be at 10% versus non-smokers at 2.5%. So really, it's just showing you that obviously these risk factors are contributing to disease development, and it puts them at, this apparent amount of risk, essentially. There's many factors that can contribute to risk or considered risk factors, essentially. A lot of them can be age, just general factors, gender. Certain disease states are more common in men versus women. Diet is a huge thing. Exercise is a big thing. And some of these are modifiable, meaning diet and exercise that we can actually try to prevent disease, essentially, through this as well. Family history of disease is a significant one. You think of things like breast cancer, colon cancer, heart disease. Those all have an influence on risk. So when you're looking at your patients, we always look at like their family history, and it'll kind of settle in more as we go through the class. There is a complex interaction between genetic and non-genetic factors. This is a huge component too. So you have that genetic predisposition there, but there's non-genetic factors that are environmental that can increase that risk there, or basically each factor can be quantified too in terms of relative risk. So really, it's the interaction between genetics and environment and lifestyle, essentially. So they all contribute to disease development. I left these questions in there. You can go through these. If you expand on the PowerPoint, it'll open up at the bottom for the notes, and it gives you the answer on there and explains it. So what's correct in terms of relative risk? You can go ahead and take a look at this. The answer is number 3. The chance of developing a disease relative to an exposure. New cases, that would be, number 1 would be referring to incidence. When we're looking at a proportion of a population with the disease at one point in time, that would be prevalence. The ability of a causative factor to produce a disease is pathogenicity. So you can take a look at this. It's pretty straightforward. Principles of multifactorial inheritance. Overall, in general, number 1, multifactorial disease is probably one of the most common things that you'll come across. And these are just things that are like heart disease, cancers, even, hypertension, things like that, meaning that there's multi-factors that basically impose risk on the patient that develops disease, essentially. And I just added these images on there. So really, when you think about this, it's a complex interaction between our genes, which may be multiple genes, may not be just one gene, and the environment. So those factors kind of interplay together, and a lot of times the environmental factors will trigger, like a genetic change there essentially, and that's why we end up with presentation of the disease essentially. When you would look at terms like polygenic traits, this means that it's number one, it's only genes. We're looking just at genes, not the environment necessarily or lifestyle with this. It's basically what genes are causing disease. And it can be multiple genes. You might have multiple different genetic causes to one disease state essentially. But once again, it's not really including that environment there. Where multifactorial traits, basically environmental factors cause variations in the traits. And when we're saying traits, that just basically means presentation of the disease. So it's, once again, it's a interaction between environment and genetics, essentially. Quantitative traits are considered, many of them are considered multifactorial traits. And these would be things like blood pressure, weight, height. These tend to follow a normal bell curve. Like, I'm sure you've heard of a bell curve. And here's the example of the chart on the right with a normal bell curve. Meaning that there's like an average in the patient population, and it tends to follow this normal, typical pattern, essentially. The big thing that we're going to really talk about is multifactorial traits. So a lot of times, a lot of these genetic alterations contribute to disease, and it could be things that they have a genetic mutation from environmental factors, or you'll hear the terms like methylation, where the environment influences your genes, and there can be methylation of DNA, essentially, which triggers disease. Another term that you often will hear, too, is genetic heterogeneity. And a really good example of this would be like coronary artery disease. So it's a combination of risk factors like high blood pressure, high cholesterol, diabetes, even family history. So all of these risk factors are actually considered a disease in their own right. Like, you know what I mean? Like diabetes is a disease, and high cholesterol is a disease in its own right, but they're also contribute to coronary artery disease, if that makes sense. So when you're thinking about patients and when you see your patients, you have to start thinking about those risks. Okay, they have high blood pressure, they have high cholesterol, they have diabetes. So then obviously they're at significant risk for coronary artery disease, essentially. And this stuff you probably kind of already have a good foundation in already. Another thing too is like Alzheimer's disease, or even mental health disorders, or insulin-dependent diabetes. There's there's a lot of different things that can interplay here with the development of it. The threshold model is essentially a way to look at risk, essentially, and where it turns into the presentation of disease. And certain disease states will have a liability distribution, and it doesn't follow that normal bell-shaped curve. And I have an example on the next slide, but the trait essentially either appears to be present or absent in individuals. And once they pass that threshold, essentially that's when the disease presents. Before that, they don't have the disease or they don't have the trait. It doesn't follow normal inheritance patterns of single gene diseases. So there's either like a low end of getting the disease or a high end of getting the disease. And there's certain things that are known about certain disease states, like pyloric stenosis, that boys get it more frequently than girls. So the threshold or liability of distribution there changes for boys versus girls, meaning that boys, it's a lot easier for them to have this or have pyloric stenosis versus a girl getting it, or baby. And I'll talk about that in a minute. But so below that threshold, essentially, they're normal. They don't have the trait. They don't have the disease. Anything above the threshold, that's when they, present with it. Good examples would be pyloric stenosis, and it's in your textbook as well. Pyloric stenosis is actually narrowing of the pyloric sphincter right above the stomach, and it presents in babies a lot. And it's easily correctable, a lot of times either through treatment if it's mild, or actually a surgical intervention with it. But it's much more common in boys versus girls. So that threshold there is more so for the boy, meaning that they have the higher chance of getting it, essentially. Neural tube defects, cleft lip with palate or without palate, club foot, and then there's other things of like congenital heart disease. So basically, depending on, some of the genetics there and environmental factors that can trigger these, essentially. Another one is autism. It's much more common in boys. It's like a 4-to-1 risk there for boy versus girl. Another thing too, like when you look at some of these multifactorial inheritance diseases, Alzheimer's is another one with that, dementia. Um, it like if you look at Down syndrome, which is trisomy 21, um, Alzheimer's actually has a link with that same chromosome 21. So when we look at Down syndrome patients, they end up with dementia very early, and it's actually an Alzheimer's dementia. And it's because it kind of works at that, there's a genetic factor for Alzheimer's on and chromosome 21 alongside with them having trisomy 21. So essentially, I don't expect you to memorize. I'm just trying to give you examples of essentially how sometimes these factors or these presentations of diseases, whether it's like a heart defect, they can occur alongside with other ones. Like sometimes you'll see, even with Down syndrome, you'll see a clubfoot, like potentially, not always, but you can. There are neural tube defects. Sometimes you see clubfoot with it. So there's other stuff that kind of go alongside with it. The big thing, though, that I kind of meant to go back to, though, like these liability, like when we look at, diseases that we can, or modifiable risk factors that we can work on with our patients, like exercise and diet. So we really want to prevent them from crossing over to above that threshold. So if there's things that we can do to prevent that, obviously that's the areas that we want to work on with our patients. This is just an example, and it's in the textbook. The liability distribution shows the threshold for males versus females. At the top, obviously, is male, bottom female, and this is for pyloric stenosis, essentially. So there's a lower threshold for males and higher for females, meaning that it's a lot easier for boys to get it than girls, or it's a higher risk in boys versus girls for pyloric stenosis. When we look at recurrence risks, it can be very hard to determine multifactorial diseases because there's a lot of different factors that have an interplay with disease development. There's a lot of genes, and unfortunately, we don't know we know a lot about genes now, or genetics essentially, but there's still so much unknown. So a lot of times there's other areas that we still have not been scientifically developed, or we don't have knowledge on at this point. Sometimes too, the environment, we don't know exactly which component may have, triggered this, or, there's multi-environmental factors that can trigger it. So once again, it's hard to determine. Reoccurrence risk on multifactorial diseases can substantially change because of gene frequencies, the environment, and lifestyles that can differ among a population. So once again, it's kind of hard to pinpoint because these factors can change so much, whether, it's the lifestyle or environment, essentially. But we do look at, when we look at multifactorial diseases, we look at reoccurrence risk. So a good example, like something basic, if you think about like heart disease, the risk becomes higher if more than one family member is affected. So if you have a patient that has a very strong family history of heart disease, like a first-degree relative, a parent, a brother, sister, the risk is higher for your patient, essentially, because of, the amount of family members affected. So these are just things to kind of keep in mind. If the expression of the disease in the proband is more severe, then the reoccurrence risk is higher. Proband essentially is the first presenting person to have it. The more severe the presentation, obviously there's a significant gene expression there. So the reoccurrence risk in other members essentially is higher. If that proband is less commonly affected sex, then the reoccurrence risk is higher. So meaning a good example, once again, is cardiovascular disease or coronary artery disease. It's more common or prevalent in men. However, if you had a first-degree relative that was a female, that had an MI at the age of 50, the reoccurrence risk is higher. So when you see that, I hope that makes sense, but like if you had a first degree relative that was a female versus a male, the risk is higher for that patient versus like a male in the family. Risk for disease usually decreases rapidly in remote related relatives, so obviously it decreases as the further away that it is to that patient, essentially. You can go ahead and take a look at this and expand on the bottom. I put some notes in there as well. I put a note example on like the reoccurrence risk of ventricle, I'm sorry, ventricular septal defect, or it's a heart defect essentially. And it, the reoccurrence risk basically becomes higher if they have a sibling that has it or two siblings that have it, it's even more. But go ahead and expand on that and you can read it at the bottom. So really when we think about this, you always hear nature versus nurture. Really it's looking at the effects of genes in the environment. Obviously nature is more that genetic component in what we inherit essentially through our families. Nurture is more of that environment, what factors are kind of interplaying with disease development or prevention of disease. So really you got to think about it too in terms of preventing it. Attempt to determine the relative influence of genetic and environmental factors is useful. Once again, because this is how we pinpoint preventative care. This is how we introduce screening, like colorectal cancer. We know that there's a higher risk as the person ages. We know that there's a higher risk in those patients that have a family member with first-degree relative with colorectal cancer, so we start screening earlier. So we change the way that we care for our patients in terms of preventative screening or even treatment of disease, like we might be more aggressive with them based on family history or those genetic components and environment. Do they smoke? Do they not exercise? Do they have high cholesterol? So really it's starting to think about all those other factors. Two research strategies that have been commonly done to look at genetics and environment are twin studies or adoption studies, because you can look at the role between the two of them. So a lot of times they'll look at monozygotic twins, which are identical. So there's natural clones, and their genetic, their genome is essentially the same. Where you have dizygotic twins are fraternal twins, and they're non-identical twins. So a lot of times they'll compare monozygotic versus dizygotic twins, essentially. Don't worry about knowing coordinate trait or discoordinate trait. I mean, obviously it's good to know, but I'm not going to test you on things like that. I just want you to understand that this is how we can study the environment and how it plays on that as well. So a lot of times children that are born to parents that have a disease but then are adopted by parents that do not have the disease are studied for reoccurrence. So they're looking for that interplay of the environment on disease development. So trying to figure out how much that genetic component actually plays a role in disease development. Gene-environment interaction, so looking at that genetic predisposition may interact with the environmental factor to increase risk for disease to a much higher level than either factor would alone. So it's looking at both of them. Really, it takes the interaction between genes and environment to trigger this, essentially. Genetics of common diseases. Congenital malformations, obviously, I'm sure you've heard a lot of this before. A lot of congenital diseases are obviously present at birth. They're born with that, and a lot of them are multifactorial. A good example would be like neural tube defects, like spina bifida. In moms that are pregnant, we always want to make sure that they're on folic acid. There's been links with low folic acid levels in moms or pregnant women in the development of a neural tube defect. So now we always make sure, obviously, that they're taking folic acid, in their prenatal vitamins. So a lot of times there's not only a genetic component there, but there's also other factors that, cause it as well. Clubfoot hydrocephaly, sometimes seen with spina bifida. So sometimes you'll see other congenital malformations kind of go together in almost like a syndrome where they have multiple ones that have that basically they can have other disorders with the congenital disease. Another one, too, an example that I can think of is retinoid products. Like there's certain meds or medications that obviously have, you don't want pregnant women on, obviously, and I'm sure you already know this, but that's another example of like an environmental factor that can trigger disease. Like retinoid products have been linked with birth defects. There's a lot of meds that you can't take during pregnancy. Another good one is rubella. Rubella infections during pregnancy can have significant effects on the baby and congenital malformations. So that's why we introduce immunizations, essentially. So when we look at this, there's some major areas that you really got to be aware of in terms of genetics and the environment. And I'm sure you already know this, but heart disease, number one, is one of them. If you have a patient that has a family history of heart disease, that's a red flag. So you really want to look at everything there. What kind of risk factors do they have? So obviously you pretty much know what heart disease is and what can happen, and you can have an MI, and you can also have strokes. So that's the other thing when you're thinking of heart disease, it's not just the heart. It has peripheral vascular disease. They may have PAD. They may have an increased risk for stroke. So really when you're thinking about these two, it's their entire system, their whole vascular system can have atherosclerosis, not just the heart essentially. And we'll talk about that in cardiac, but once again, risk increases if you have more affected relatives. So if they have more family members that have heart disease, they're at more higher risk. If they're female versus male, they're at higher risk because it's more common in men versus women. So if they have remember when I mentioned about if that relative is female, then they have a higher threshold there essentially. If age of onset's younger than 55, so the younger the onset, the higher risk the other family members can be at. There's other different factors that can interplay with this too, like familial hypercholesterolemia, which is very, very significant. I mean, we're talking, this is a genetic disorder essentially where they have very, very elevated lipid levels, and we'll talk about this later too, and it's like through the roof. And it's inevitable for them to have heart disease and an MI, essentially, if it's left untreated. And there's new meds out there like Repatha that we use for this state, essentially. But so like, once again, that's genetically inherited. So that would contribute to heart disease as well. But other things like general things, high-fat diet, lack of exercise, smoking, obesity, those all increase the risk. So it's multifactorial, essentially. So it's genetic and environmental. Hypertension, one again, obviously you know what hypertension is, a risk factor for heart disease, stroke, kidney disease. 20 to 40% of blood pressure variations are genetic, meaning that environmental factors are really important here too. So that's why we always make sure we're doing the preventative measures and making sure that we're discussing other things like exercise, smoking cessation, low sodium diet. There is a genetic link there, though. You'll have patients that you see that have hypertension and you would never think that they would have it. You know, they may be thin, they look healthy, they may exercise, and they still have hypertension. The same thing with cholesterol. You'll see that where it happens, and that shows you how genetic it can be, unfortunately. Blood pressure regulation is very complex, so this can be, there's a lot of different genetic components that might contribute to this, like the renin, angiotensin, and aldosterone system, which regulates your blood pressures with your kidneys and your nervous system, essentially. We'll talk about all that later, but these areas essentially can have genetic influence too, which then ultimately affects the patient's blood pressure, but we'll talk about that later. So there's multiple factors essentially there. Cancer, once again, I'm sure obviously you know that it's very prevalent. It's the second leading cause of death in the United States. Many cancers obviously occur in families, whether you're thinking about breast cancer, colon cancer, prostate cancer. So a lot of these run in families. There's a genetic link there. So obviously environment and lifestyle also affect that too. You think about lung cancer would obviously with tobacco, colorectal cancer sometimes too with diet. So you got to think about both there. Tobacco does account for 1/3 of all cancers. So it's not just lung cancer, it can contribute to the development of other cancers, like bladder cancer is common with, but it can affect other areas too. With these, sometimes there's non-inherited mutations or genetic mutations that can contribute to it as well. So it's not just inheritance, but that's why like things like tobacco can cause these mutations, you know, from chronic irritation, you know, causing tumor development. So it can be both, but obviously you got to think in the back of your mind, there's a high genetic link there. Breast cancer is another one of them, obviously, too. There's a genetic link there, and I'm sure you've all have heard of, the BRCA genes. But a lot of times, well, I should start at the beginning, I'm sorry. The 12% of women who live to 85 years of age can have breast cancer. So that's a high rate. That's a very high rate. Once again, I'm sure you know, if you have a first-degree relative with breast cancer, then the patient's risk will double. That's high. That's very high. So a lot of times, patients that have breast cancer or a family first-degree relative, sometimes, they choose, or you should recommend or discuss it with them about genetic counseling. Because sometimes there's that, genetic link there with the BRCA genes, one or two. And the other thing, too, is, those genes are also associated with ovarian cancer. So when you're looking at breast cancer, you always got to think in the back of your mind that risk factor for ovarian cancer is there as well. And that's usually more related to those BRCA genes where you have that genetic component there. But look at those rates there, 50 to 80% of lifetime risk of developing breast cancer, and increases the risk for ovarian cancer. So that's with the BRCA gene. So, those are things that we have to discuss with patients. There's other genes that are implicated with breast cancer development as well. So obviously there's not just these two, but that's why genetic counseling a lot of times is important in these patients too. I'm going to go ahead and split this into two different quick videos. That way it's just easier on when I upload it to Moodle. So just go to the next one and I'll have the rest of those slides on the next PowerPoint. Thank you.